Today's course is about pre and post-operative management of trauma and orthopedic patients. I've also covered a bit of introduction to ward-based care and trauma and orthopedics as a whole. So it's a good introduction talk just to get us started for the course. So as everyone's seen, I'm guessing because you've managed to sign up, this is our fracture school poster for course number 2. So this is the syllabus for this 6 sessions. So today is pre and post-operative management of T&O patients. Next week is neck of femur fractures, followed by upper limb injuries. The week after is lower limb injuries and head injuries, and the last one is spinal injuries. So the objectives of today is to go through introduction to trauma and orthopedics, ward-based care, discuss common orthopedic and trauma admissions, and we'll discuss pre and post-operative management. So an introduction to T&O. So it's a surgical specialty which covers trauma, which is all the acute problems, and it covers orthopedic elective surgeries as well. So trauma usually covers acute fractures, polytrauma, which means the patient has more than one fracture, tendon and ligament injuries, and also infections such as cellulitis of the skin or bone infections, osteomyelitis. The elective side, with the ever-aging population, we deal a lot with arthritis, osteoarthritis in particular, and do a lot of joint replacements, hip replacements, knee replacements, shoulder replacements. We also do soft tissue repairs, such as rotator cuff repairs in the shoulder. We do ACL repairs in the knees, and also nerve decompression, so such as carpal tunnel syndrome, which you would have heard of. This picture down here just shows a broken radius bone and ulnar bone, and this one here shows what a total knee replacement is. So we cover it with metal, plastic, and metal again. So how do trauma and orthopedic patients get to the ward to begin with? So there's an acute pathway and there's a planned pathway. So the acute pathways are people who have come through accident and emergency, the urgent care centre, and sometimes people are so unwell we have to admit them from clinic. The planned pathway is some of our trauma patients who are waiting at home with broken arms or legs. We tell them to come in on Friday or Thursday to come in for their operation. So they'll come into the hospital for their specific operation and may stay over one night. And the last bit of the planned operation pathway is elective surgery. So elective surgery was our hip replacements, knee replacements, shoulder replacements, and other soft tissue operations. And these patients are often planned months in advance to come to hospital. So going down the acute pathway, these are the people who have had their injury, they've fallen over, they've got hit, or they've got a infection on their arm or leg, and they come through A&E or through clinic or urgent care. And they're generally seen by the on-call orthopedic team, and they have a clerking for admission on their notes, which in our hospital is online on a computer system, and in some hospitals are still on paper. These types of people are usually broken bones which need surgery, or they are broken bones and they're unable to go home. So if you imagine an 80-year-old lady with an ankle fracture, people with ankle fractures have a cast on their leg and they're not allowed to walk. So this 80-year-old lady, although she may not need surgery, she's not going to be strong enough straight away to start using crutches. So they are sometimes admitted for occupational therapy and physiotherapy to help them adapt whilst they're in a cast for about 6 weeks. Other people admitted are tendon and ligament ruptures for surgery, such as you may see patella tendon ruptures around the knee, quadriceps tendon ruptures also around the knee, sometimes bicep tendon ruptures. Infections, so cellulitis is infection of the skin. We have many of these, people who have got scratched on their arm or a little wound which suddenly becomes infected, and also joint infections, either with a total knee or total hip replacement inside, or just an infection of a normal joint, and osteomyelitis is a bone infection. In our hospital and some hospitals, orthopedics also takes the head injuries through A&E. So this includes any bleeds inside the brain, which the neurosurgeons just would like to admit for observation. And we also take spinal injuries, which includes fractures or ligament injuries. If we go down the planned pathway now, so these patients are usually arranged by the trauma coordinator, or they're arranged by elective theatre bookings team days or months in advance. And the trauma aspect of it are usually broken bones for surgery and broken tendons and ligaments for surgery, but they're actually well enough to go home. Joint replacements, ACL repairs, injections into steroid injections and nerve decompressions, they're the ones which are arranged months in advance. They come for pre-assessment and then come into hospital. So that's a summary of how trauma and orthopedics get to your ward to begin with. So where to find the plan for the patient. So for our acute pathway, which is through A&E, UCC, and admissions from clinic, you should find a plan on the T&O Clarkin. For the patients who have come in just for surgery, we will have our plan for them on the post-operative note, which is the operation note, which in our hospital is on paper, but other hospitals may be online. What information will you find on these documents? So for the T&O Clarking acute patients, you will find a diagnosis, or at least a working suspected diagnosis. You will find a weight-bearing status. Should the patient be walking? Should they be non-weight-bearing, or can they be partially weight-bearing with crutches? You will find a plan for antibiotics if they have an infection. You should find a line which says an operation is required. You will find nil-bar mouth status if they're going for surgery the next day. And the Clarking will also have important information such as their past medical history, whether they have any heart or lung problems. It will have a list of their medications, their allergies, and also their social history. So it's a useful documentation. From the planned aspect, as mentioned, the patient just comes in, goes straight to theatre, and the documentation is mainly afterwards. So you'll find it on the operation note. You'll find the operation that's been performed, again, their weight-bearing status, IV antibiotics. So post-operatively, most people have a couple of doses of antibiotics post-op. They are prophylactic antibiotics to help reduce the risk of infections after surgery. You will find the VTE prophylaxis. So with everyone with ankle operations or lower limb operations that cannot walk, they will be on Clexane for the whole time they can't walk. Other patients, such as upper limb patients, they may be on Clexane in hospital, but they won't always require it post-operatively. On the operation note, you'll also find an estimation for home. So it'll either be home the same day or home the next day following assessment from physio. You also find the follow-up plan. So we'll see them in clinic after 1 week or 2 weeks. Common admissions. So you'll commonly see these sorts of people on our ward. So this patient has a plaster cast on his right leg, which is below the knee. This patient has a plaster cast on their hand and wrist. This patient has a polysling. This is a Futura splint. And this is another plaster cast, which is a bit lower down, covering the ankle. And this is a humeral brace. You won't see this one so often, but occasionally this is a brace which is quite solid. It goes around the humerus, which keeps this bone here, humerus bone, aligned. It's for fractures. And this is the collar and cuff element, which goes around the neck and the wrist to keep the hand elevated. So preoperative care. So one very important aspect of preoperative care is fasting. So usual fasting instructions is no food 6 hours before surgery and no water 2 hours before surgery. The only difference is necrophema patients, they are prescribed a carbohydrate loading drink. These count technically as fluids, and they are allowed as prescribed 2 hours before surgery. And there's another one which is even earlier than that, but you can give it as prescribed. So often you'll see just near my mouth from midnight written down, but everyone is allowed water, I say, until 6 in the morning, because no one's going to be operated on before 8. So my general instructions are no food after 2 in the morning. And after that, they can have plain water until 6 a.m. Why do we fast people preoperatively? So imagine you just had lots of food and lots of drink. It all goes down here into the stomach. When the patient is lying flat on the anesthetic table, and when the general anesthesia is given, when the muscle relaxants are given, all your muscles and all your normal reflexes are inhibited. So all the food and fluid which is storing here with all the gastric juices, as someone's lying down, it can track backwards. There's normally a kind of blockage here, which stops any fluid going into the trachea. The trachea is the tube which is attached to your lungs just here. So when you're asleep under general anesthesia and muscle relaxants, this block reflex here is stopped, and the food and fluids can come here. They can go into the trachea, and that's what causes an aspiration pneumonia, chest infections. So that is the main reason why people are not allowed to eat and drink preoperatively. What counts as food? So literally everything apart from plain water counts as food. So you cannot give someone squash, you can't give anyone juice, you can't give them tea, coffee, milk. You can't give them chewing gum. Chewing gum, the problem with it, even though you don't swallow it, it produces lots of juices in your stomach because your stomach thinks you're about to eat. So your stomach is still filled with gastric juices, which again, when you go to sleep with general anesthesia, it can always track up and into the lungs, causing the aspiration pneumonia. Any amount of food counts. So if someone was supposed to be near my mouth and we're about to take them for theatre, and for some reason they've had 1 teaspoon of yogurt, or they've had 1 bite of a biscuit, that is exactly the same as having a whole McDonald's meal. So if they've eaten anything in those 6 hours, we can't take them for theatre. Preoperative care in regards to medical tests. So all preoperative patients who don't have done, and we do these routine tests, and this looks at the full count and what we're interested in, hemoglobin level. So do they have enough red blood cells going around their body to provide oxygen to the area we're about to operate on? Urea and creatinine, this looks at the kidney function. So will their kidneys be able to manage with the general anesthesia and the shock on the body? Liver function looks at the liver as suggested. And again, it looks at how well your body's going to cope with the liver. Will the liver clear all the drugs we're about to give it? So will it clear the general anesthetic? Will it clear the muscle relaxants? Will it clear the opioids and the antibiotics we're about to give? And also important with liver function is clotting. So if there's a problem with the liver, the body may not be able to produce clots, and it can make the person bleed much more than you would like. Clotting, again, as I mentioned, how well is the body going to stop you bleeding too much? And group and save and cross match, which I'll describe on the next page a bit more. So group and save, this test requires preferably 2 bottles, 2 samples, which are taken at 2 different times. And what the lab do is they test your blood group or the patient's blood group, and they store it on the system. So it's just that we know the blood group and it's there for everyone to see. The difference with cross-match is we're actually asking the lab to test the blood and get some blood ready for us. So if you know someone is B positive, we would ask the lab, can you get ready 2 units of B positive in the fridge in case we need it during surgery? And that would be there if there's too much bleeding intraoperatively. If we don't do a cross match and we urgently need blood, if we call the blood bank, if they get the B plus blood that you actually need, it can take about 20 to 30 minutes. So in those emergency situations, we use O negative. But as you can imagine, it's much better to have your own blood type if available. So what operations need group and saves, and also 2 units of blood ready in the fridge in case they lose too much. So we always cross match for 2 units of blood for hip surgeries. So for dynamic hip screws, intramedullary nails, hemiarthroplasties, and total hip replacements. We also get 2 units of blood ready for femur surgery, which you'll see written down as ORIFs, open reduction and internal fixation. You'll see it for intramedullary nailing and also plating. Total knee replacements, and also shoulder operations. So these shoulder operations include replacements of the shoulder joint. They also include plates and nailings. So the reason we get 2 units at least ready for these patients is because they're quite big surgeries. There's quite big blood vessels around all these joints. So if there's any complication, then these patients can lose blood extremely quickly. Everyone also requires an ECG. This checks the heart rhythm for any abnormalities. Again, before a patient is giving general anesthesia, this can affect the heart. So we do want to know about any abnormalities before rather than during the operation. Some patients also have echoes. These are a jelly scan on the heart, which can be done on the ward. And this mainly looks at people who have heart failure to see how much blood is actually being pumped out of the heart and provide to the rest of the body. And it can look for any structural heart problems, such as valve problems. You may see on our wards that some of the neck of femur patients who are a bit older, they do need echoes before they have their surgery. Paperwork. So we know in the NHS there's a ton of paperwork. Now, unfortunately, the patient cannot leave the ward until all of the following paperworks are actually completed and present with the patient. So the surgeon will do the consent form. The anaesthetist fill out a review form, and they usually write their recommendation of whether they're going to do a block, a spinal, or a general anesthesia. The VTE assessment is usually done by one of the doctors, either the surgeon or the anaesthetist, and mentions if we need to put beds on the patient. And there needs to be a theatre booking, either by paper or on your computer system, whichever your hospital uses. For the ward healthcare professionals, what we need to take someone to theatre is the patient notes. Or every patient needs a wristband. Every patient needs to be in their hospital gown. They need to have TED stockings on both legs unless there are any contraindications, and you usually don't put them on the leg that we're operating on. And all hospitals usually have a surgical checklist, which is a surgical ward checklist different to the WHO one. This one is something done by the ward team, which mentions which operation the patient's going for, which belongings they have, if the consent form and essential paperwork is all present. So post-operatively on the ward, you want to be doing regular observations of the patient, so which includes your full heart rate, respiratory rate, blood pressure, oxygen saturations, and temperature. Also important to look at is the urine output. IV fluids is usually running as people come out of theatre, so usually the bag is still going. You want to monitor the dressings for any excessive bleeding. So we've got some scenarios now for post-operative care. So this is scenario number 1. Some of the scenarios are a bit extreme, but it gets you thinking as to what complications could potentially happen post-operatively. So this is a 65-year-old man who had a hip hemiarthroplasty just now. Their blood pressure is 80/40, which is low. The heart rate is 110, which is high. The respiratory rate is 25, which is also high. And the temperature is 37.3, which is normal. He lost 1.5 litres of blood in the theatre, which is quite a lot for a hemiarthroplasty. But looking at his dressing and his leg, his dressing is dry. and there's no hematoma or bleeding that looks like it's coming out. So what do you think? Just have a think, and you can write it in the chat. What do you think is causing this patient to have a low blood pressure, high heart rate, and high respiratory rate? Is it A, active bleeding? Is it B, hypovolemia from the intra-op blood loss? Is it C, anaphylaxis, or D, normal? This scenario shows hypovolemia from intraoperative blood loss. So it's not active bleeding because the dressing is dry, and looking at the leg, there was no hematoma or big swelling. So 1.5 litres is actually quite a lot to lose from a hemiarthroplasty. It'll be more looking towards 200 to 500 mils of blood being lost in that operation. And most because they've lost so much intraoperative, kind of catching up with them at that point. So if you're on the ward, you want to call a doctor for this patient. If you're a medical emergency team, you can call them as well. And if you have a peri-arrest team or outreach team, if the patient's not improving or the patient's blood pressure gets even worse, these people you want to have in your head to be calling if you need to. So we always approach unwell patients or complication patients with the ABCD approach. So for the airway, you give everyone oxygen. You give an unrebreather mask, 100% oxygen, 15 litres per minute. This is in the acute unwell patients. For the breathing aspect, you want to be looking at the respiratory rate and the O2 sats. For the circulation, you want to look at the heart rate, the blood pressure. Now we know this patient is hypovolemic, so they've lost blood. They don't have enough volume going around their body, so we need to fill up the volume in their veins and arteries. So we get access with cannulas. You need 2 of them preferably. So if you are based on the ward, it's good to get, if you can cannulate, then cannulate. If you cannot, then just get the equipment ready and wait for one of the doctors to come, and they can do that. Hopefully, you want to be thinking about definitely get some IV fluids there, which would be given to the patient. As they've lost a lot of blood, some doctors may order a blood transfusion. Good to take a blood test as well, because their hemoglobin may be really low, but you wouldn't have had a blood test since the operation. A blood gas as well, that would give you a quick hemoglobin level, so you know what kind of anemia you're dealing with. Disability is a D, so you want to make sure the patient stays alert, which is the A. As they get more unwell, they become alert to voice, they become alert to pain, or the worst is they're unresponsive. And E is everything else. So check the operation note, check how much blood did the patient lose in theatre. And if you see the 1.5 litres, then you'll be thinking this is why the patient's like this. And you want to look in the anaesthetic chart to see how much IV fluids has been given. So the main treatment for hypovolemia, get IV access with cannulas, get IV fluids, probably going to get some blood, I would, and do some blood tests to see where you're at. And at the beginning, calling the doctors, calling the medical emergency team. All right, scenario number 2. An 85-year-old lady had a femoral nail. Her blood pressure is 120/80, which is good. Her heart rate is 79, which is also within the normal limits. Her respiratory rate is 7, which is extremely low. Her temperature is 37.4, which is normal. And her O2 sats are 90%, which for people post-operatively is low. You try and wake her up, but she's drowsy. She's keeping her eyes closed, making a few noises. You try and look at her pupils, and they're very small. They're pinpoint. Both of them are. You learnt from our first scenario, and you looked at the operation note, and you saw the intraoperative blood loss 300 mils, which you know is okay for that operation. You check her dressings, and they're dry. So again, if you could write in the chat, do you think it's A, anaphylaxis, B, active bleeding, C, opioid toxicity, or D, this is a normal patient post-op? So the answer for this one is opioid toxicity. So the key signs in this scenario for opioid toxicity are: number one, their respiratory rate is extremely low at 7. The pupils are pinpoint and the patient is very drowsy. And if you think of intraoperatively and also just post-operatively in recovery, we give lots of patients opioids. So we give them morphine, we give them codeine. So it's definitely important to check the anesthetic note and see what's happening. So for this patient on the ward, you definitely want to call a doctor or your medical emergency team. You want to give the patient oxygen, as we give for all of the unwell patients post-op, 100% oxygen, 15 litres per minute via a non-rebreather mask. Check the respiratory rate and the oxygen saturations. And as we did before, the same for the circulation, disability, and everything else. For this one, as I mentioned, check the drug chart for opioids and check the anesthetic chart for how much opioids they were given. The treatment for opioid toxicity is to give naloxone. This can be given IV, and in America they have a name for naloxone. I haven't seen it here in the NHS hospitals potentially, and they need constant observations. The naloxone is very short acting, so after you've given one dose, it works quickly, but it doesn't last long. So the patient will arouse quite quickly, but they will become drowsy again after a few more minutes. So you have to be ready there for another dose. But naloxone is the key for opioid toxicity. Scenario number 3. So a 75-year-old man had total knee replacement. He tells you he's got central crushing chest pain. His blood pressure is slightly low at 100/70. His heart rate is raised at 110. The respiratory rate is 30, which is also raised. Temperature normal at 37.4, and the O2 sats are low for him at 89%. His intraoperative blood loss is 400 mils, which you know is satisfactory, and the dressing is dry. So is this patient having a heart attack, gastric reflux, constipation, or a chest infection? So that's looking great. So the answer is well, I mean, it's not good for the patient, but yeah, he's having heart attack, myocardial infarction, the other word. So this is a realistic complication which happens post-operatively. So anyone who's having chest pain, we need to act extremely promptly. So for this patient, you're going to want to call your peri-arrest team, your medical emergency team. You need to get everybody there ASAP. Again, with the A, you start them on the oxygen. You do their normal respirate, you do their oxygen saturations. As much monitoring you can get on the patient provides, when the MET team come, it provides them with so much information they can act much more promptly. So you want to do the heart rate, blood pressure. Again, IV access is a common occurrence. You need it for all unwell patients, and preferably 2. So again, get the stuff ready, or if you are able to cannulate, then do the cannulation. ECG is the important one for the heart problem. So if you get that machine, sometimes it's not based on your ward, sometimes it's on the ward next door. So as quick as you can get that will save time. Again, checking the alertness of the patient, and check the anesthetic chart, because it could have been a drug they were given which has started this off. And the main treatment when the medical team arrive, they usually give antiplatelets, they give morphine, they give some sort of low molecular weight heparin, and some patients have to go for urgent coronary intervention. So they put stents which go through the femoral artery in the groin up into the heart, and they expand the artery again with some stents. The next scenario, so a 35-year-old lady has an ACL reconstruction. So this is a knee ligament reconstruction. You see her on the ward. She just come back from recovery, and her face is swollen, her lips are swollen, and she's got a rash all over her body. Her blood pressure is a bit low at 110/90. Heart rate is a bit raised at 100. Respirate's raised at 25. The temperature is normal at 37.4. And the O2 sats are 93%, slightly low for her. The intraop blood loss is 150 mils, which is completely fine for an ACL reconstruction. and her dressing is dry. So is she having a heart attack, having anaphylaxis or an allergic reaction, a pulmonary embolism, or a chest infection? The answer is B, an anaphylaxis allergic reaction. This is one you work extremely fast with. You just call the medical emergency team. If you have a peri-arrest team, they call them. If you don't have a peri-arrest team, then you call your the 2222 cardiac arrest team. Stop any drugs which are currently going through the patient. So if anything is going through the cannula, stop it, and then you need to actually unscrew it from the cannula, and you actually need to take out that cannula, but I would make sure you can get some other access at the same time. So again, unwell patient, oxygen, 100% oxygen, 15 liters, non-rebreather mask. Check all their observations as before, get the access, take the bloods, check the anesthetic chart for what they may have been given, double check with their allergies, because sometimes it unfortunately does happen that they're given something they are allergic to. And some hospitals have an anaphylaxis box, where it's all in the correct in place that be which will involve adrenaline, chlorphenamine, and hydrocortisone. You want to get the adrenaline as fast as you can. This is IM, which makes it even easier. So other complications which can happen post-operatively, these ones you may see either this, later in the day, you may see it after a few days or even after a week post-operatively. So anemia is extremely common in orthopedics, particularly with the big bone surgeries. So you would check their bloods and they've got a low hemoglobin. Generally, when you see them on their ward in the bed, they're quite tired. They might have difficulty doing some physiotherapy because when they stand up, they're lightheaded. And these patients need blood transfusions or iron replacements, which can be with tablets or with IV replacement of iron. Pneumonia is another complication post-op. So what you would see when you're on the ward doing observations, you'll see low oxygen saturations. The patient may be coughing with phlegm coming out. And if you check the blood test, there'll be a high white blood cell and a high CRP. Their treatment is oxygen and also IV antibiotics. Constipation is a very realistic issue after surgery. We give patients lots of opioid medication, codeine 4 times a day. We give them Oromorph, and all these things slow down the bowels and they get constipation. They'll be complaining of abdominal pain, and there'll be quite a number of days between their normal bowel movements. So for them, they get laxatives. Some people will have glycerol suppositories and some even enemas. Urinary retention. So they have abdominal pain, usually in the lower aspect, and they're not passing urine for a while. If you do a bladder scan, they'll have a lot of urine in their bladder and they'll need to be catheterized. Electrolyte imbalances can happen mainly of sodium and potassium levels, usually due to the general anesthetic. So they can cause confusions or arrhythmias. So on their drug chart, you may see doctors prescribed the potassium Sandoz tablets, IV potassium replacement, IV fluids, or they may be on a fluid restriction where they can only have 1 liter or 2 liters of fluid a day. DVT, so deep vein thromboses. This is quite common in orthopedics, and it's because people with any ankle fractures, shin tibia fractures, knee fractures, and some femur fractures, they're either in plaster or we say they have to be non-weight bearing. When you're not weight bearing, your calf muscles, they're not pumping blood, which means the blood is staying stagnant in that area and the blood can just start to clot. They have calf pain and calf swelling. So that calf is usually bigger than the other one. They need an ultrasound Doppler, so a jelly scan of their legs, and then we put them on treatment dose Clexane if it's confirmed. Pulmonary embolism is another one which is related to a DVT because it can be due to the stagnant blood in the calves causing the DVT in the calf, which can then travel up into the lungs. So for them, they'll be complaining of chest pain. So your other differential would be myocardial infarction, heart attacks, but you get your ECG, you inform the doctors, and they'll get a CT pulmonary angiogram, which looks at all the blood vessels in the lungs. And again, they get treatment dose clexane. Some of them get a strong medication which disintegrates all the clots. So post-operative plans for upper limb surgery. So you want to check the operation note for everybody, but the main thing is in all orthopedic operations is to elevate the limb. So for the upper limb, you want to elevate, if they're sitting on the chair, you want the hand to be above the heart, preferably. And one thing to remember is the fingers need to always be higher than the elbow. So this is if they've had hand surgery or wrist surgery. So you want that bit to be higher so all the fluid drains. If they're like this, all the fluid comes down, you'll see that their fingers are ginormous like a balloon, and they'll start to get tingling because their nerves also get compressed here. So elevation, if they're sitting, is all like this, fingers higher than the elbow. If they're in a sling, the arm should be like this. It should not be in a sling like this. There's no point having a sling like that. The sling needs to be with like this. If they're lying down in the bed, because they will have to go to sleep, in this diagram you can see there's a pillow on the side of the left arm, and it's keeping the fingers higher than the elbow. If someone has shoulder surgery or humeral surgery here, they will not be able to sleep flat. They will be extremely uncomfortable, and they'll have to sleep with the bed tilted upwards, so about 30 degrees, or even in a sitting up position. So don't be surprised if that's the case. And actually, with them laying down, it may cause more swelling in the shoulder and humerus. So keep them up. Neurovascular observations. So around the wrist, there's 3 big important nerves, the median, radial, and ulnar. And they're also present around the elbow and up here. And we are extremely worried with some fractures with their function, because they can be squashed with the fracture, or they can be squashed with the operation and even injured. So we ask you to check their feeling, neurovascular observations. Can they feel you touching their fingers, and does it feel normal to the other side? And can they move their fingers? You want to do an OK sign, spread their fingers out wide, and do their wrist movements. We'll cover that in depth in the upper limb session. And you also want to make sure they have a pulse. So do they have a radial pulse here? And are their fingers nice and warm? Pain relief for everybody post-operatively. And if you've operated on that arm, there'll be non-weight bearing, which means they can't carry any objects with that arm. You may see patients post-operatively with a sling. So either a cast on their arm, the poly sling I showed you earlier, or a Futura splint. For the lower limb injuries and operations, again, check the operation note. We would like their leg to be elevated. So if they are sitting on a chair, they need something that's actually higher than a footstool to elevate. So you want to get their leg as high as they can. And when they're laying in the bed, they need about 3 or 4 pillows underneath their leg. 1 pillow will not do much at all. And again, the reason we're worried about elevation with lower limb operations is because they have plaster on, and if things get too swollen, it interferes with the nerves, and it can also cause compartment syndrome. Neurovascular obs, again, feeling if they can feel you touching their toes, can they move their toes, and are their toes warm? Pain relief for everybody, weight bearing status. This is a common aspect of orthopedic surgery. So what you'll see on operation notes is these bits on the left. So FWB, full weight bearing. This commonly for patients who have hip surgery, total hip replacements, they can walk fully afterwards. Hemiarthroplasties, they can walk fully. DHS, femoral nails, tibial nails, and total knee replacements, they can all walk normally after the surgery. PWB is partial weight bearing, which means they can put some weight on the leg, but not 100%. And this happens in people who have on the femur, your thigh bone, it's on the distal femur plating, which you'll see in the operation note as an ORIF, or periprosthetic fractures, where people have a fracture around their knee replacement or around their hip replacement. This is the post-operative instruction. So we fixed it with a plate, but we need them to partially weight bear. TTWB is touch toe weight bearing. This means they can put their toes on the floor, but not the rest of their foot. So it's extremely little amount of weight going through. This can be, again, for the same operations as above, distal femur open reduction, internal fixation with plates, or periprosthetic fractures with plates. Non-weight bearing is a lot of our operations, so ankle surgeries, foot surgery, and plating of the tibia. They can't put any weight on at all. You'll see people with casts on. This one on the right here is a hinged knee brace. And this is usually just wool and crepe. And we put the wool and crepe on just for the first kind of 48, 72 hours to help with compression to reduce the bleeding. So the learning points for this session was introduction to ward-based orthopedic and trauma cases and care, common T&O admissions, and pre and post-operative management of trauma and orthopedic patients.